Good morning, Professor Steer.
Good morning.
Now, let me tell you, before you're sworn, which Mary will ask you to take the oath in a moment or two, you're talking to a select group here in Aldwych, but there is a much wider audience who will be watching what you have to say out there through live streaming, just so that you know. We will take a break after round about 11:15. During that break, the rules are that at any break, you must not discuss the evidence you've given with anyone, whoever they are, but you can talk about anything else you like.
Thank you.
Mary.
Please state your full name.
Philip James Steer.
Take the book in your raised hand and repeat after me. I swear by Almighty God
I swear by Almighty God
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing but the
and
truth.
nothing but the truth.
Yes.
Thank you. Professor Steer, I just want to start by working through with you an overview of your career so that we're clear on what you've done. You qualified in 1971, is that right?
Yes, correct.
And then you specialised in obstetrics and gynaecology with training posts around London.
Yeah, correct.
In 1981, you became a senior lecturer in obstetrics and gynaecology and an honorary consultant at St Mary's Hospital. In 1989, you became a professor and head of the academic department of obstetrics and gynaecology at the Charing Cross and Westminster Medical School.
Correct.
What were you responsible for in that post as head of the academic department?
My responsibility was primarily to ensure appropriate training of undergraduate medical students and also to develop research. Those were my primary responsibilities. I also had the usual clinical responsibilities of a consultant, similar to my NHS colleagues. And separate to that, I was for various periods given a clinical role as director of maternity on one occasion, director of perinatal medicine on another, and so on. But that was separate from my academic role.
And at the same time as you're becoming a professor, I think you also moved your clinical practice over to the West London Hospital. And then in 1993, your clinical work moved to the Chelsea and Westminster Hospital, and that was when that hospital opened.
Correct.
You stayed there until 1997, when the hospital, you stayed at Charing Cross and Westminster Medical School until 1997, when it then merged into and with Imperial College.
Correct.
And at that point, you became head of the academic department of maternal fetal medicine.
Yes.
Was that significantly different to your role as head of the academic department of obstetrics and gynaecology?
In academic terms, I then had a purview across Queen Charlotte's Maternity Hospital, the Hammersmith Hospital, and St Mary's Hospital, where I'd originally trained. So I was responsible for overseeing academic activity on all of those sites, but my clinical responsibility remained at Chelsea and Westminster.
And then in 2003, you became deputy head of division, responsible for a number of aspects of undergraduate teaching. Yeah. And is it right that at that point your academic oversight became much broader than just obstetrics and gynaecology?
Correct. Imperial continued to reformulate the various departments and incorporate larger groups, and that continued, in fact, until I retired.
And you retired in 2007?
Yes, as head of, as professor.
But remained working clinically until 2014?
Correct.
I want to spend most of this morning looking at particular contexts in which blood transfusion is used in the obstetric practice. But before we do that, can I turn to transfusion much more generally and your training when you first qualified? Could we look at HCDO 40861, please? This is a booklet from 1973 called Notes on Transfusion. And if we turn to page 3, please, Sully. We can see a description of the booklet that the inquiry's looked at before. This edition of Notes on Transfusion, like the 4 previous editions, has been prepared by the Committee of Regional Transfusion Directors, etc. The booklet is intended primarily for use by medical staff of hospitals, and its purpose is to describe briefly some of the principles of the practice of transfusion and to suggest procedures. And it says the notes aren't exhaustive. Is this a booklet that you were aware of as a trainee or as a junior doctor?
I have no recollection of having seen that document before, no.
No. So it's not something that you're aware of ever having been provided with? When
I may have been, but I have no recollection of it.
Thank you. Could we just turn to page 4? And if we go into the first half of it, it says this, and then I'll ask you a question about it, Professor Steer. Transfusion therapy should be undertaken only after careful assessment of the patient's clinical condition to determine the nature and quantity of fluid to be transfused and the rate of administration. The patient may require whole blood, concentrated red cells, or other blood components, or one of the special plasma fractions. And then in bold, a transfusion should never be given without a definite indication. Not only is this in the patient's interest, since an element of risk is associated with every transfusion, but supplies of blood are not unlimited, and with the ever-growing demand for blood, it's imperative that it should not be used unnecessarily. The use of transfusion to correct moderate or slight degrees of anemia that could be overcome as effectively, if more slowly, by other means, seems unjustifiable unless some cogent reason for speed of recovery exists. How closely or not does that fit with what you were taught in your early years of practice, before you even specialised in obstetrics?
It seems appropriate, an appropriate policy, and it's one that personally I always tried to follow.
I'm aware from your statement that you took a perhaps more conservative approach to blood transfusion than many of your colleagues in obstetrics and gynecology, and that's something I want to talk with you a little bit more later today. But just in terms of your early training as a junior doctor, does this fit with that training, or does this represent a difference to what you recall being trained?
No, I think in my training, giving blood was seen as a very important and altruistic thing to do, and each blood unit that was given was seen as something that people had given freely to benefit others, and therefore should always be treated with respect, and therefore never used lightly, as it were. And I certainly personally always had the view that with each unit of blood came that responsibility to make sure it was used correctly.
And then if we turn on to page 18, we have the heading at the top, transfusion records. A record of every transfusion should be made in the patient's case notes, in addition to the details recorded in the transfusion laboratory. It's not always appreciated that the main reason for accurate recording is the protection of the patient. Again, how closely does that fit with what you were taught in your very early years of practice?
Well, I don't remember being taught it specifically, but I do remember that taking the sticker off the unit of blood and making sure it was firmly fixed in the patient's notes was considered very important and critical. And I commonly would write, in addition, the details in pen, because sometimes if you stuck the label in, even with sellotape, over the years the sellotape would dry out and these things would drop off and get lost. So I thought it was always useful to make a written note of it as well.
And as a junior, was that something your seniors were drumming into you, as it were, or was that something that you were just very conscious of?
It was, I would say, actually, the nursing staff were particularly assiduous in encouraging that. They saw that as a very important part of their responsibility, and therefore we did as well.
And moving forwards to 1989, could we have PRSE 3047, please? This is a document called the Handbook of Transfusion Medicine. It's the update, effectively, from the notes. Again, is this something that you would have been aware of as a clinician in 1989?
I don't recollect it, no.
We can take that down. Thank you, Sally. Then just very generally, how as a clinician in the 70s and early 80s would you expect documents like that to reach you as a junior practitioner, as a junior clinician?
The teaching during the 70s was largely by apprenticeship. And so the teaching was almost all verbal on the spot, and it was see one, do one, teach one, which was a very sort of well-known expression, and in my experience, often true. The working hours were very long, as I put in my statement, so the average was 108 hours a week. So some weeks it was a lot more than that. There was very little time, really, in one's life to read all these extra documents that might appear in the hospital. So basically, you were just reading what you thought was absolutely essential and relying on your seniors who were supervising you to make sure that your practice was appropriate.
And following from that, would it be fair that there may be seniors who were more assiduous in certain matters than others?
That's always true, I guess, yes.
In terms of your understanding of the risks of infection from blood transfusion, can you tell us what that was from your medical training, so taking that very early period?
Yes, well, as a medical student, I worked closely with a medical student from the year below me, who was the junior secretary of the Listerine Society when I was the senior secretary. And he subsequently worked with the renal department at King's and unfortunately got hepatitis B, from which he sadly died. And so we were always aware that infectious disease was a very important risk to be aware of. And of course, in those days, we're coming out of the 60s, when even things like polio and other infectious diseases were relatively common and caused sort of national concern. And infectious disease was still seen as really, really important because antibiotics were still being developed and a lot of infections were still difficult to treat. So I think we were very aware of the importance of avoiding infection whenever possible, asepsis. So for example, in maternity, we would gown up and put masks on and use gloves and so on for suturing episiotomies in a way, or inducing labour or whatever. There was a lot more emphasis actually on aseptic procedure, which lapsed a little bit later on because of antibiotics becoming more effective.
And in terms of blood transfusion specifically, do you recall any training as an undergraduate or as an early clinician on the viral risks of transfusion?
Not specifically, no.
And then you say in your statement that in the mid-1980s you became much more aware of the risks involved of viral transmission. Why was that?
That was largely because of the HIV problem starting to appear. And my personal involvement was that I was actually providing medical care to somebody who was one of the early researchers in the incidence of HIV infection. And she naturally took the opportunity when I was taking blood from her or whatever of saying, this is how you must do it to avoid transmitting infection to yourself or to other people, etc. And then subsequently, because of my sort of heightened awareness, I guess, I became aware of somebody that I thought might have HIV infection who in fact turned out to have it. And then that sort of snowballed, so that because people knew that I'd taken an interest in this area, that such women started to get referred to me for supervision.
And so your clinical practice developed to particularly include women with HIV?
Yes. That's when I started, for example, double gloving. And I can remember on one occasion, we having to ring one of my colleagues who'd moved on to work in another hospital just to warn him that he'd done a cesarean section on someone who subsequently turned out to have HIV and he should get himself tested. Those were in the days when being tested for HIV was still quite stressful because people were anxious about what they would find out.
And in terms of your roles within the medical school and the education of undergraduates, what teaching did students receive about the risks of viral transmission from blood transfusion in the early 80s?
I'm not aware of that because that wouldn't have been my particular responsibility.
So in terms of the obstetric and gynecology training, that wouldn't have included anything specific about blood transfusion and viral risks?
No, I mean, we started teaching medical students very thoroughly about the risk of HIV transmission generally, and the fact that this could be transmitted via blood, and blood stick injuries, etc., were of great concern. I mean, for example, if you had an accidental needle stick from someone who either had unknown status or was HIV positive, you had to go and have blood taken and be given antiretrovirals and then have follow-ups and so on. So it was really difficult. I mean, it was very prominent in day-to-day practice that this was a significant risk. So I guess we just assumed that such a risk would be present in transfused blood, and that as soon as we became aware of that risk, there were tests becoming available to find the virus, and therefore we presumed they were being applied so that the blood we were giving was HIV negative.
So as an obstetrician, I think what I'm hearing is you say that you were very reliant on the haematologists to both train the medical students in their block about the transfusion, and clinically that the blood that was being provided would be screened once the tests were available.
Correct.
In your statement, as I flagged earlier, you've said that you've always been conservative when it came to giving blood in your clinical practice. Can you tell us how that came to be, why that was?
Well, I was first introduced to the idea that women who are pregnant have a lower average hemoglobin concentration by David Paynton, who was the reader, senior lecturer and then reader in the department. And he was very formative in my academic training. He was certainly an important mentor for me. And as a result, I became familiar with his work, previous work, showing the fact that because the plasma volume expands faster than the red cell volume, they both increase, but the plasma volume increases quicker, the concentration of red cells during pregnancy falls. And I was aware, more than many people, of just how significant that fall is. The average fall in pregnancy is about 10 grams per litre, and in some really healthy women who have a high hemoglobin to start with, it can be as much as 30 grams per litre, and that puts them well within the range which is, in non-pregnant people, regarded as being anemic. But I was aware, because of this research that I was familiar with from David Paynton, that this was probably inappropriate.
I'd like to go to that research so that others can also be aware of it. WITN 6977003, please. I think this is the paper that you're referring to.
Yes.
And we can see that it's by David Paynton, the size of the total red cell volume in pregnancy. The first, I'll just read a bit of it out and then ask you something. Since the plasma volume increases during pregnancy to a greater extent than the total red cell volume, the hemoglobin concentration decreases as gestation proceeds. Some have regarded these changes as physiological adaptation to pregnancy, but others have been unwilling to accept this hypothesis because the administration of iron preparations will minimise or even prevent the fall in haemoglobin concentration in most pregnant women. And then on the next column, please, Sully. towards the middle, if the decrease in haemoglobin concentration in pregnancy is regarded as physiological, it is necessary to define the limits of normality so that anemia can be diagnosed with confidence. I think the paper then discusses difficulties of measuring that. But is that essentially the point that you understood from David Paynton, that if you understand the drop is actually physiological, then there's no need to boost it back up?
Correct.
And if we just turn to page 3 of the paper, it shows the extent of the drop. There's a table at the top. If we can turn it round. Thank you. The figures from his study, and the first line is the haemoglobin. So at 11.9 weeks mean gestation, the mean is 12.6, dropping to 11.7 by 20.5 weeks at mean gestation, 11 by 28.9 weeks, 10.9 by 36.8 weeks, and then rising again to 11.9, 7 to 8 weeks postpartum. Very practically, in terms of your own obstetric practice, what changes?
Just before we leave that, if we look at the MCHC, that tells you how much hemoglobin there is in the circulating blood, does it?
Yep.
And despite the drop in hemoglobin concentration, that remains pretty constant.
Exactly, and I've always emphasised in my teaching looking at the mean cell volume is another straightforward way. In the majority of women, that doesn't change significantly. And that was one of the things that suggested to me that this is physiological. It's what is sort of optimal to happen and not a genuine anemia. I think the confusion has arisen because if you define anemia as less than 11 grams per decilitre or 110 per litre, the women are defined as anemic. But I think the word anemia is inappropriately used in this context. The other thing just to point out from that table is the range, because you'll note that at 11 to 9 weeks, it's around about 12 weeks, the range for the hemoglobin is 11 to 14, which is pretty similar to the non-pregnant. So that's about 10 weeks is when the hemoglobin starts to fall. We've done a lot more research on this since. And so that would be appropriate to take 11 as a cutoff at that point. But if you look at the range at 36 to 38 weeks, it's 9 to 13.
Yes.
Very different.
Yes. And I suppose, is it a lay understanding, proper lay understanding, that because the MCHC remains constant, in effect you've got just as much hemoglobin in your bloodstream, you've just got a bit more bloodstream?
Yes. Part of the ongoing discussion, which continues to this day, is the knowledge that in many parts of the world iron deficiency is real and does have long-term health consequences. The issue is to what extent does some degree of iron deficiency in pregnancy in well-fed, healthy people in high-income countries, is that actually part of the physiological process, and that actually just having a good diet after you've been pregnant will restore that. That's been my view, but not everyone accepts that, and that's why the argument about routine iron supplementation has continued. It isn't current policy to recommend routine iron supplementation in the UK at the moment, and I think that personally that's the right policy.
So you're winning the argument?
It's taken a long time, but I think gradually the needle has shifted a little bit in our favour, yes.
Thank you.
And just to place the timing of this paper, I think this was published in 1962.
Yes.
And it followed a paper by Simpson in 1954, which commented that the MCHC, mean corpuscular hemoglobin concentration, remained liable, remained
the same. Yes. And actually cast doubt on the concept that the fall in hemoglobin in pregnancy was properly called anemia. He considered that it wasn't.
Yes. So just in terms of the dating of that understanding, it's very early on.
Yes. When you say that understanding, you mean it was there to be understood?
So thank you for correcting me. It was in the medical literature
Yes.
and available for people to read and understand. That leads me to my next question, Professor Steer, which is, having that understanding yourself, what impact, very practically, did it have on your clinical practice in obstetrics?
Well, it meant that, firstly, I wouldn't regard a normal fall of hemoglobin in pregnancy in an otherwise healthy woman as an anemia requiring to be treated. If the hemoglobin fell below 10 grams per deciliter, then I would do the additional tests and look at ferritin and iron stores and so on, if necessary. But in practice, I found that if it fell below 10, simply giving women an iron tablet every couple of days was sufficient usually to restore that back to a level above 10. So my usual practice was simply to say, here's some iron tablets which we gave out free. If you can manage to take 3 or 4 a week, that should sort you out. And that, in fact, the Cochrane database of studies has looked at all the evidence on this and has shown that, in fact, that sort of iron administration is as effective as giving an iron tablet every day. And certainly there's no benefit from giving 2 or 3 iron tablets a day. It's simply trying to pour more water into a bucket that's already full. You can't absorb that much iron.
And in terms of your colleagues' practice, either within the hospital or more broadly in obstetrics, what awareness did they have of this matter?
It's very difficult. I think probably at least half of my colleagues sort of understood it, but I got the impression until I retired that there was still quite a lot of people who still preferred the simplistic, oh, well, if you're anemic outside pregnancy, then you're anemic in it at the same level. And certainly one's experience was that women were coming up from their GP, commonly being prescribed iron tablets, sometimes 2 or 3 a day, to the extent that actually a few years ago, I actually wrote a long article in a GP magazine explaining all this background, trying to persuade general practitioners that a hemoglobin dropping to 10 in an otherwise healthy woman didn't require any treatment. It was actually a good sign rather than a bad sign.
And in terms of the use of blood transfusion for women during pregnancy, did that affect your colleagues' use of blood transfusion as well?
I don't think that was the major influence. No, I don't think many of my colleagues would give a transfusion based on a woman simply having a lowish hemoglobin. I think that was more related to the idea that if you needed to give some blood, it was always better to give 2 rather than 1 in case they bled again later. That, I think, was much more common.
Which we'll come to in just a moment. Just to finish this piece of the jigsaw, you have continued to work on this issue in your research, and in 1995 you published a paper, WITN 6977005, please. It's headed "The Relation Between Maternal Hemoglobin Concentration and Birth Weight in Different Ethnic Groups." It was published in the BM, the British Medical Journal, in February 95. The objective was to assess the relation of the lowest hemoglobin concentration in pregnancy with birth weight and the rates of low birth weight and preterm delivery in different ethnic groups. It was a retrospective analysis of 153,602 pregnancies with ethnic group and birth weight recorded on a regional pregnancy database during 1988 to 1991. The hemoglobin measurement used was the lowest recorded during pregnancy. And if we just go down to the results, please. Results and conclusions. Maximum mean birth weight in white women was achieved with the lowest hemoglobin concentration in pregnancy of 85 to 95 grams per litre, so 8.5 to 9.5. The lowest incidence of low birth weight and preterm labour occurred with the lowest haemoglobin of 95 to 105 grams per litre. A similar pattern occurred in all ethnic groups. Conclusions: the magnitude of the fall in haemoglobin concentration in pregnancy is related to birth weight. Failure of the haemoglobin concentration to fall below 105 grams per litre indicates an increased risk of low birth weight and preterm delivery. This phenomenon is seen in all ethnic groups. Some ethnic groups have higher rates of low birth weight and preterm delivery than white women, and they also have higher rates of low haemoglobin concentrations. This increased rate of, quote, anemia, however, does not account for their higher rates of low birth weight, which occurs at all haemoglobin concentrations. So in a sense, this is the follow-on study that showed the interrelationship between haemoglobin and low birth weight.
Yes, this paper did actually have a significant impact, and it's been one of my more highly cited papers, I'm pleased to say. So,
in order to tackle and challenge the idea of anemia in pregnancy. And then in 2005, we won't go to it, you also published a paper with Dr. Brockhard showing that perinatal mortality was lowest with haemoglobin concentrations in the third trimester of between 9 and 11.
Yes.
And just for the transcript, the reference is WITN 6977006. Moving on then from...
May I just ask, is there any evidence to show that deliberately topping up someone who has a concentration in that level on the basis that it's thought to be anemic, the double inverted commas around it as you put in your article, is there any evidence that actually does some harm?
Yes, not topping up in terms of blood. I don't think anyone would think about doing that. That level would not be low enough to indicate that. But there have been quite a number of studies looking at supplementation of otherwise healthy women, and you can show their hemoglobin rises significantly, and a number of these papers have shown increases in the incidence of low birth weight and preeclampsia, particularly in what we call the upper quartile. So the women who have the highest increase or response to the iron have worse outcomes as far as their baby's concerned. Most of these effects don't seem to be played out in the mother in the short term. Longer term, it's much more difficult to follow them up. Most of this work is related to the outcome for the baby. So there does definitely seem to be some potential harm if you increase the hemoglobin by giving iron in women who are not iron deficient.
Yes. And that's quite an important message to get out.
Absolutely, absolutely.
Thank you.
Moving on from pregnancy, would it be right that there are two main situations in obstetrics where a blood transfusion would be given? One for anemia post-delivery, and the other in terms of an obstetric hemorrhage, whether that's antenatal or postnatal, but a hemorrhage situation.
Correct.
Can we deal first with the anemia scenario? When would you have given a blood transfusion for anemia postnatally where there's not a significant hemorrhage?
Well, the answer is I was always very reluctant to do so. I don't actually remember doing that on the basis that, in my experience, the women would respond very rapidly to being given oral iron and replace the blood count themselves. I mean, the hemoglobin can recover by about 1 gram per deciliter, 10 grams per litre a week. And I know from personal experience in relation to my family, my son, for that reason, every week for a year to get, and the end of the year was when he started. So I think the speed at which healthy people can replace their blood is widely underappreciated. It's remarkably rapid.
And in terms of your colleagues, you've said in your statement that wasn't the approach of many of your colleagues. Can you help us by describing what the practice generally was in the late 70s, early 80s and through to the late 80s?
Well, part of the problem is that if a woman's had a difficult labour or very long labour, or she's bled a lot during the delivery or even had a caesarean section, very often in the postnatal period, she's tired and feels exhausted and difficult to breastfeed and so on and so forth. And her hemoglobin then is commonly low. So there is a general perception that, oh, well, if we give her some blood and bring her hemoglobin level up, that will sort of pep her up, make her feel less tired and improve the outcome. I was always very doubtful that that was of any value. Certainly in my experience, when I saw other people doing this, the benefit only seemed to last 48 to 72 hours, following which, to be honest, I couldn't see any ongoing benefit. And to my knowledge, there are no studies which show a significant benefit more than about a week to 10 days at the most. After that, the outcome seems to be the same, whether you'd given blood or not. So it always seemed to me, for that temporary small improvement, the risk of giving blood meant that it wasn't appropriate.
And did your colleagues and other obstetricians have a rule of thumb of the haemoglobin level that meant a transfusion should be given?
Well, it was commonly 80 grams per litre for a long time. In the last 7 to 8 years, various publications, including the New England Journal and so on, editorials have suggested that that should be reduced to 70 grams per litre. And I think probably people are now more aware of that than they were when I was practicing.
And in the very early days, the inquiry looked at a number of documents on Monday, which suggested that a haemoglobin of less than 10, then a transfusion should be given. Was that the situation in obstetrics as well, or was it 8 all along?
Well, certainly as far as I was concerned, 10 wouldn't have worried me because I regard that as normal in many women. Since I wasn't directly involved in other people's management, I can't really comment on other people's views, other than I know that it was more liberal in terms of giving blood than mine commonly.
And when would an iron transfusion be given rather than a blood transfusion?
Well, some women do have difficulty taking tablets. In my experience, if you then offer them a liquid preparation, which is readily available in the NHS, then they will often be able to cope with that. If they seemed either reluctant to have either or didn't appear to respond, then an intravenous iron infusion would be appropriate, because if they had a hemoglobin of 6 or 7, then clearly they needed some boosting, and they would need to have their iron stores improved in order to do that. I was familiar with the initial substances used, such as iron dextran, that they could cause allergic reactions. And in fact, I can't remember the specific case, but I remember have a vague recollection of being aware of such a case. So I was always a bit cautious about giving intravenous iron. There are more recent preparations which are less allergenic, but there is still some risk to giving anything intravenously in terms of an acute reaction if somebody's allergic.
And in terms of those early iron infusions, you've described in your statement that you were aware of them in the 1980s.
Yes.
Was that a relatively recent option in the 1980s, or had they been around for a rather longer?
Honestly, can't remember. They've been around for a long time. I can't remember exactly when they started.
Could I turn now to WITN 6977001, which is your statement, Professor Steer. In your statement, you've included a table that I want to look at. Page 13, please. We have here a table that you've very helpfully produced in relation to answering a question at any of the institutions at which you've worked, how many patients per week would receive a transfusion under the care of the department. And you've said at St Mary's it was about 1 every 2 weeks. At Chelsea and Westminster it was similar initially, but increased to about 1 to 2 a week as the number of deliveries increased. And so we've got the table in relation to St Mary's Hospital and also West London, Chelsea and Westminster. And these both relate to postnatal transfusions. Can you, just in terms of what we're seeing, we see in St Mary's in a figure of about 42 transfusions in 1988, increasing to 50 in 89, and then dropping somewhat before increasing again to 1994, and dropping. And in Chelsea and Westminster, it slowly, it sits around 40 to 50, and then peaks at 76, 1989, in 1994 and onwards. Is that because in the Chelsea and Westminster there's been an increase in deliveries?
Yes. I don't see any obvious statistical trend in terms of the proportion of women getting transfused.
No, it's broadly the same proportion throughout.
Yeah.
Can you help us with, do you have any sense of the number of women who were transfused postnatally for anemia in these figures rather than hemorrhage?
Oh, no. I would be able to look at the women having a transfusion at the hemoglobin level when they booked in pregnancy and the lowest level that they achieved, well, was measured during the pregnancy. I could probably do that, but I haven't done that.
No. And then after this table, you say this. At St Mary's, the relatively conservative approach pioneered by David Paynton, and which I continued personally, persisted after I left. But as the number of consultants at Chelsea and Westminster increased, I found it difficult to persuade some of my colleagues to be equally conservative. Can you help us with why that was? What were the difficulties that you faced?
I can't really say, in the sense that I'm not sure that all individuals would know why they had those policies. I mean, it would almost need a psychologist to work out why they're not convinced by the data. It's something that, as an academic, I've always been intrigued by, why clinical practice sometimes seems at odds with what the scientific evidence suggests to me is appropriate.
Did you have any conversations with colleagues that you can relate that gives us some indication of what their concerns were?
Well, the last specific discussion I had with a group of colleagues was back in 2016 when we were presenting our data on the number of women having 1 versus 2 units. And my research fellows, now consultant at St George's, presented our data and said, look, we should not be giving 2 units to so many people who clearly only really need 1. And I was surprised at a number of colleagues who said, oh, well, no, we think it's a good idea. You know, if you've got 2 units cross-matched, you might as well give the woman a boost and she'll feel better and her recovery will be speeded up. Despite the fact we'd already presented the evidence that from our academic point of view, this was not justified. So I didn't have the opportunity to ask them specifically why they didn't agree with the evidence that we presented, but that was still... I actually had a discussion with him a couple of weeks ago and said, can you confirm that my recollection of that meeting was correct? And he said, absolutely. He was just as surprised as I was at the reaction of some of our colleagues.
I want to look at that paper in just a moment, but just picking up on that 1 unit versus 2 units issue. Is it right that when transfusions were being given to women to top them up in the sort of 1980s, single unit transfusions were being used in many situations?
Well, I wouldn't say in many situations. I mean, my policy was always, if the woman becomes hemodynamically unstable or compromised, then you give blood until that resolves, and then you stop.
Yes.
And then you keep whatever is left in reserve in case they bleed again. But, you know, again, my recollection is a lot of my colleagues felt that, oh, it's better to be ahead of the game. Give the extra unit, and then you won't suddenly be called to the ward because she's collapsed again or something like that. So it was precautionary. So I could understand, in a sense, where they were coming from in that regard. I mean, subsequently, it's not just in the UK. About 10 years ago, I actually went and spoke at a meeting of all the trainees in Sweden about postpartum hemorrhage and raised this issue. And they confirmed that in Sweden, this was a similar thing. People tended to give 2 rather than 1. And as I said in our paper that we published in the International Journal, that seemed to be true in the US as well. So this seems to be not just a British phenomenon. It's quite difficult to persuade people that once they start giving blood, you should just give the minimum. they always seem to want to give a bit more just to be on the safe side. That's the only way I can explain it.
If we pick up that, I hope the paper you're referring
Yes.
to, WITN 6977008, please. It's a paper headed the retrospective surveys of obstetric red cell transfusion practice in the UK and USA, first published online on the 13th of September 2017. And if we just look at the abstract, objective, to examine whether professional guidance promoting a policy of restrictive blood transfusion is being followed. Methods, a retrospective analysis of post-delivery transfusion data from 17 maternity units in the UK, 1988 to 2000, was undertaken. Additionally, an audit was performed of women receiving 1 or 2 units of red cells 6 to 24 hours after delivery at 3 centres in the UK and USA in 2013 to 2016. And the conclusion is current transfusion practice deviates from evidence-based guidelines. Either by default or long-standing tradition, more women receive 2 rather than 1 unit, despite similar estimated blood loss.
Yes.
And then if we just turn to page 2, it gives us the results in a at the bottom of this page, then over to the next, results of the 513,101 deliveries with a documented estimated blood loss recorded in the North West Thames database between 1988 and 2000, 10,269, which is 2%. Apologies, I suddenly couldn't see if there was a spot there or not. 2% women received a postpartum blood transfusion at any time from delivery to discharge from hospital. Of these, 303, which is 3% of women, were given 1 unit of red blood cells, and 4,397, which is 42.8%, were given 2 units. The median estimated blood loss was similar in these 2 groups of women, 600 ml versus 700 ml respectively. And then we see discussion. The present study has shown that in the postpartum period, obstetricians more commonly prescribe 2 units of red blood cells rather than 1 unit, even when the estimated blood loss and pre-transfusion haemoglobin level suggests that 1 unit would be sufficient, i.e. there was no correlation between estimated blood loss and the number of units transfused. Women were prescribed blood even when their haemoglobin concentration was equal to or greater than 70 grams per litre, with some greater than 80 grams per litre, and were 10 times more likely to receive 2 units than 1 unit. This practice was observed in the more recent audit of all 3 centres studied. Despite evidence demonstrating the clinical benefit of a restrictive transfusion policy in most settings, current transfusion practice in maternity care continues to deviate from recommended guidelines both in the 2 UK centres and in the US centre studied. However, the unfounded belief that 2 units is better than 1 is not unique to obstetrics. And then you cite Barr et al. And then over the page, the last paragraph, clinicians continue to overuse blood transfusion in obstetrics, and the use of a single unit transfusion remains uncommon, although the proportion of women receiving a blood transfusion could have just decreased over time. The present findings from a historical 1988 to 2000 and contemporary 2013 to 2016 audit demonstrate that at least some obstetricians in both the UK and the USA have not responded to recent guidelines recommending a lower haemoglobin threshold, 70 grams per litre, for postpartum blood transfusion. Other obstetric institutions should audit their practice to see whether contemporary guidelines, such as the Choosing Wisely campaign, are being followed. When overuse of blood transfusion is identified, we recommend the implementation of educational programmes and protocols to reduce blood use and to encourage restrictive policies. So that was your findings as recently as 2017. And in terms of the education programmes and protocols, how would that flow happen in a hospital? How would that information from the journal reach other clinicians?
It's mainly if they read the article. Since I'm no longer in practice, I don't know whether there have been any specific recommendations made in those hospitals from the management perspective as such. There was a famous paper in the Journal of the Royal Society of Medicine that suggested that from finding out something factually by research into implementing it in clinical practice on average took about 25 years. And that is certainly my experience in many areas, including this. I think it's taking a long time to turn the oil tank around.
And that reflects your experience with your own colleagues in trying to present the material and encourage them to change their practice.
Yes.
If we can just go back a stage to the real nuts and bolts of having a transfusion in obstetrics. If a transfusion was required, still staying with the postnatal anemia scenario, and I'm very aware that you didn't particularly give a transfusion in those situations, but just very practically, who would make the decision to transfuse? What grade of doctor would make that decision?
Well, commonly the resident doctors, the house officers and the registrars would be going around on a daily basis, sometimes twice a day now. And if they came across a woman who they felt was struggling, tired, difficulty in breastfeeding and so on, they would check their hemoglobin in case they had a greater blood loss than had been appreciated at the time, which is not uncommon. It can be very difficult to assess blood loss that accurately in a busy clinical situation where it's sort of spread across all the drapes and so on. And then depending on the value found, they would think perhaps this woman should have a blood transfusion. And then usually it would be a discussion with either a senior registrar or the consultant about the appropriateness of that. And then having decided whether it was medically appropriate, the next step would be to go and talk to the woman and say, you're obviously having difficulty, you are anemic, and a blood transfusion may be appropriate. What do you think about that?
And then once the blood had been obtained from the blood bank,
Yeah.
how would information about the transfusion reach the medical notes?
Well, the clinical history that led up to the decision to give a transfusion would be recorded in the notes. And then obviously there would be a request form sent to the hematology department. They would then send the blood back, and the medical staff would be notified when it was available. Whoever was going to give it, usually the medical staff would put up a drip for doing a blood transfusion. The midwifery staff might well put the blood up, and usually they would have a colleague, a midwifery colleague, who would cross-check everything. It was one of the odd things about medical practice that if they were all busy and you were asked as a doctor to do it, to give an injection or even put up blood or whatever, it was generally considered, well, you can do it. And I would say, but I need somebody to check it. And they said, oh, no, you're a doctor, it's okay, which I thought was inappropriate. I did always do my best to get someone else to cross-check any such things, to make sure you were giving the right blood to the right person, or indeed giving them the right injection of antibiotics or whatever it was. I just felt that it was appropriate to encourage that sort of safe procedure. Before doing it, of course, you'd sit down and explain to the woman the indications for it, and there would sometimes, well, there would nearly always be a discussion about, is that safe, doctor? And so the general response is, well, blood has been checked for everything that we can check it for. In recent years, because of the experience with prion disease and so on, one has to say there's always a remote possibility that there's a new infectious agent that we haven't yet discovered that's in the blood, but all we can say is that everyone's made their best efforts to make sure it's safe. And then the blood would be administered with the woman's consent.
And then you talked earlier of putting the blood sticky label in the medical notes.
Yeah.
Was there anything else that you recall making
Well,
sure was in the...
I would always
You
write
wrote
the
it.
details in ink because of my experience in the past that occasionally these things that were stuck in would fall out or get lost. And I always thought that was an extra precaution that I personally preferred to do. And usually the midwives would record it as well, either in the notes or indeed at one time they would have what they called a cardex, which was a sort of cardboard log of what was happening on the ward, and it would often be entered in there. Now it would be in the electronic data systems, it would be entered.
And the cardex, was that by patient, or was it a more general ward record?
No, it would be patient by patient, yes.
Could I turn to AHCH 5049, please? This is a set of guidelines produced by the British Committee for Standards in Haematology, headed the administration of blood and blood components and the management of transfused patients. Is this something, it's from 1999, is this something that you would have seen at the time?
No.
And then if we turn to page 7, we have a heading on the right-hand column, the documentation of transfusions. And it says, good documentation of transfusions is essential, for example, so that the cause of serious adverse effects can be adequately investigated and audit of the indication for transfusions can be carried out. And then recommendations, medical notes, a permanent record of the transfusion of blood and blood components and the administration of blood products must be kept in the medical notes, including the blood transfusion compatibility report form. Is that something that you recall?
Well, I wouldn't have seen it as a form in terms of an A4 page or anything like that. I don't recollect anything like that. It was usually a sticker that was, I don't know, about 3 or 4 centimetres by 2 or 3 centimetres with all the details printed on it and perhaps added to by the haematologist, which will be attached to the blood. And very often they were self-adhesive later on. In the early days they weren't, you stuck them in with sellotape, but then they became self-adhesive and you just peeled it off and stuck it in the notes.
And then the second bullet point, the sheets used for the prescription of blood or blood components and for nursing observations during the transfusion.
Yeah, that was sometimes it would be written up on the, or commonly on the prescription chart as well.
An entry in the case notes describing the indication for the use of blood or blood components, the date, the number and type used, and whether or not it achieved the desired effect, etc. I think that's what you're referring to as your handwritten notes that you added.
In my experience, people were pretty assiduous about that sort of thing. I wouldn't have any criticism of the general standard in that regard. And as I've said, in our intensive care unit, we actually employed intensive care trained nurses, as I say, not intensive, high dependency area in the labour ward. And the midwives were also commonly, not nowadays, but at one time they were always nursing trained before, and in general were very thorough in my experience. More so, I have to say, than the medical staff commonly. I mean, they were keen to make sure that the rules were followed.
The inquiry's heard evidence from a number of women who received a transfusion during their obstetric care, where the fact of a transfusion doesn't appear to be included in their notes and can't be found in their notes. Or that the blood component that was transfused isn't there, or the specific unit numbers aren't in the notes. It's incredibly helpful to hear how you've operated, but can you assist the inquiry at all as to why errors might have arisen in the obstetric situation and how it comes to be that the notes don't include that sort of information?
Well, I can only speculate because I don't recollect personally being involved in a case where that happened. But just speculating from my clinical experience, sometimes a ward can be very busy, and if transfusion is required urgently in an emergency, it can be sometimes difficult to know where the woman's notes are, if she's been moved, for example. And so the scenario might be she's delivered in the delivery room, the notes are sitting on the side, on the table in the delivery room, the woman is moved back to the postnatal ward and then suddenly collapses. It's decided that she needs a transfusion, and at the time the notes are still in the delivery ward. And then it may be that the staff get very busy again afterwards and they just simply forget. It's just human error. I mean, these things can always happen. I don't have any personal recollection of ever that having happened, so that's just pure speculation as to how it might.
And you've indicated the problem of things falling out of notes if somebody hasn't then been assiduous about writing down.
Yeah, before they were, the self-adhesive ones tended to be better, although even then, after about 10 years, they sometimes come a bit loose.
And you described just a moment ago about the information that would tend to be given to a woman about requiring a transfusion. Could I turn to DHSC 304486_097, please? I don't expect you to have seen this before, Professor Steer, because it's a British Committee for Standards in Haematology meeting minutes, but I want to just discuss with you the final part of it, which deals with consent for transfusion. And the Blood Transfusion Task Force discussed a proposal at length. Written comments were provided. And then if we go over the page, the following conclusions were reached. The risks associated with blood transfusion were not of such magnitude that there should be a legal requirement for informed consent to transfusion. There is a clear ethical duty upon doctors to inform the patient what's to be done and to them, and this includes blood transfusion, and then there are issues around patients under anaesthesia. Just in terms of the context of postnatal transfusions for anaemia rather than the hemorrhaging situation, what's your recollection of the general practice in relation to seeking a woman's consent for a transfusion as opposed to providing information about it?
I don't recollect anyone being asked or required to sign a consent form as such. My recollection may be faulty, but I don't recollect that. The general feeling was that it was a relatively safe procedure. The woman herself would have usually been very well aware of why it was being given from her own symptoms. You had to put the drip up and then you had to get the blood and so on. So there was a lot of opportunity for the woman to say, no, I'd rather not have that. So it's not as though you're doing something suddenly or unexpectedly that requires an immediate reaction. This all takes a significant amount of time. So I don't think there was ever any anxiety about the woman not giving at least implicit consent. And it is relevant just to say that in obstetrics, for example, and I've actually presented to our risk management committee at the Chelsea and Westminster about this in the past, again, taking my lead from David Paynton, throughout my career, it was never my practice to require a woman needing an emergency caesarean section to sign a consent form, simply because she was stressed, it was in an emergency. I didn't think a signature on a piece of paper was important enough to delay the procedure in doing it. And in acute hemorrhage, that would also apply to blood transfusion. So I think we are quite used, and this is a common practice, not just my practice, but in general at the Chelsea and Westminster, certainly when I was still practicing, there was no requirement on us to get a signed consent for an emergency procedure because it was considered inappropriate. And so therefore, I think the general feeling was that implicit consent, provided you did your best to explain to people why the procedure was being done and recorded that was sufficient and appropriate.
There may not have been a written consent given for blood transfusion in the sort of calmer circumstances of postnatal anaemia, but was there an expectation that doctors would ask the woman whether she consented to it?
Oh yes, absolutely.
Rather than an implicit consent. What's the difference you're drawing there?
Well, when I say implicit consent, what I mean by that is that when you say, we've got the blood now, we're going to give it to you to counteract your anemia, are you happy for us to set this up? This is what we're doing. And she says, yes, fine, carry on. Then that would be implicit in that sense. Any hesitation or uncertainty on the part of the woman would cause one to stop and say, okay, you seem concerned or nervous, what's bothering you? Let's discuss this before we do anything. In the postnatal situation where it's not urgent, you have time to do that.
So you're using the word implicit consent to describe a process where there is actual consent, but it hasn't been, as it were, signed off by a signature.
Yes.
So it may strike some that the signature is simply a matter of process.
Yes.
What matters, perhaps, in consent is the reality of consent, which is knowing what is proposed and agreeing to it.
I have actually written articles in the British Journal advocating exactly that, which is that what we must concentrate on is making sure we give as much correct and appropriate information as possible and record that you've done that rather than requiring a signature on a piece of paper. And then when I say implicit, what I meant was that the woman is not saying, don't stop, don't give it to me, or I'm worried, or I'm unhappy. By implicit, I mean the woman is aware of what you're doing, understands the reason for it, and is happy for you to go ahead. And that's something that doctor-patient relationship emphasizes is critical.
Yes, so the word implicit perhaps is
an inappropriate word, yes.
Misleading,
Yes.
because you're talking about real consent.
It's real consent.
Not
It's assent rather than implicit
Yes.
consent, yes.
I want to move on then to the obstetric hemorrhage context. If we start, sorry, let me just, if we could turn to NHBT 5037, please. This is a document, again, from the British Society for Haematology with guidelines for transfusion for massive blood loss published in 1988. Is this a document that you were aware of in 1988?
No.
So, despite the context of obstetric hemorrhage being massive blood loss, this sort of document wouldn't reach you as an obstetrician?
No, it's in the Clinical Laboratory Haematology Journal.
Indeed.
And that's not something that's way outside my specialty, so I wouldn't normally see that.
And would you have expected the haematologists in the hospital to have indicated to you there's new guidelines for transfusion on massive blood loss?
I don't have any recollection of that happening, no.
I want to look at it just to see how closely it accorded with practice in obstetrics at the time, but very aware, of course, that you hadn't seen it. It indicates at the beginning these guidelines have been prepared in an attempt to summarise current opinions regarding the management of massive transfusions and also to identify those areas where unjustified therapy should be curtailed. In this regard, it should be borne in mind that many of the currently established transfusion practices are based more on benefits that are hoped for than those that have been proven. Was that your experience in 1988?
Just say that again.
I'm just reading from the first paragraph. In this regard, it should be borne in mind that many of the currently established transfusion practices are based more on benefits that are hoped for than those that have been proven. Is that something you recognise as an issue in the late 1980s?
I'm not sure that I would understand what they meant by that. I mean, without them specifying which benefits they're talking about, I couldn't really comment.
And then if we turn to page 5, we see the heading, a management strategy for massive transfusion, sequence of components, treat profound hypertension speedily, prompt administration of any infusion fluid is preferable to delay, in preference order give crystalloids and synthetic colloids up to 40% blood volume, followed by 4.5% albumin. Initial red cell replacement can take the form of red cell concentrates, but if bleeding continues, it may be more sensible to supply whole blood. And then if we turn the page, I just want to take you through the guidelines, then I'll ask you about them. Turn the page to choice of transfusion materials, crystalloids and colloids. These are particularly valuable for the initial stage of resuscitation before blood components can be obtained. and then it gives some indication of what should be used. Then over the page, platelet concentrates. Platelet concentrates, 1 pack per 10 kilograms, are indicated for continuous non-surgical bleeding when platelet counts are below 50 times 10 to the 9 per litre, or are falling towards that value. And then the heading, fresh frozen plasma, or fresh frozen cryosupernatant plasma. Frozen plasma, 12 ml per kilogram stat dose, or given as 25% of the plasma volume replaced, provides broad spectrum replacement for correction of coagulation abnormalities. And then over the page, red cells, concentrates and optimal additive suspensions. These will be adequate during the initial resuscitation phase, but once the need for massive replacement is recognised, it's more economical to provide whole blood. And then finally, under the heading, when to give components. For massive uncontrolled traumatic hemorrhage, maintenance of full haemostatic competence by means of component therapy may be unrealistic. In this situation, the priority is for major vessel bleeding to be stemmed surgically. Combinations of stored whole blood, red cell concentrates, colloids and crystalloids should be used to maintain blood volume or pressure, and haemoglobin or hematocrit values at greater than 7 or 0.25 grams per decilitre respectively. It is preferable to conserve use of limited supplies of fresh blood, plasma or platelets until the hemorrhage shows signs of control. 2. When the rate of blood loss is substantially lessened and after major vessel bleeding is under control, it becomes worthwhile attempting to correct haemostatic abnormalities. How closely does that guidance accord with your experience in around 1988?
That seems about right. The whole thing is, as I recollect, we stopped using albumin a bit later, and then fresh frozen plasma became less appropriate and so on. So there were changes since, but my recollection at the time of what we were doing is pretty similar to that.
Can we just go back to the very first page of that article? What we're talking about here is defined at the bottom of the page, I think. The massive transfusion is something which entails transfusion of a volume equal to the patient's total blood volume in less than 24 hours. How frequently did you come across that in obstetrics?
That's really rare.
That's what I wondered.
Just a handful of cases in my entire career would entail that much bleeding. Anything up to about 5 litres. I mean, for example, in our obstetric database, which I was instrumental in helping to design, which it's been referred to, we had an option for saying how many units of blood were transfused, and it stops at 9. In other words, if you have 9, it's just 9, even if it's 15, because it was so uncommon, we didn't think it was justified to use an extra digit.
Yes.
And when we set it up, computing resources weren't as plentiful as they are now, so we tried to keep the number of data items as small as possible to save space on the hard disks and things. So it was very rare for anyone to get beyond 9. So in 500,000 cases, it would have been a handful.
And patient's total blood volume would be what on general?
Well, in pregnancy, it can be as much as 7.5 litres.
Yes.
So it increases by 50% compared with non-pregnant. So it's a lot.
Yes.
So 7.5 litres in terms of units, that would be 15. So very, very rare indeed in my experience.
Thank you.
And in that paragraph, sir, it's probably worth noting that it refers to obstetric patients presenting with overwhelming hemorrhage.
Yes.
And by that, clearly, it really is a very significant...
Well, I think that's just been stressed, hasn't
Absolutely.
it? It's,
absolutely.
It's the management strategy is about patients who are exsanguinating. They're bleeding profusely as they come into casualty. So it's sort of road traffic accident type person or ruptured aorta or something. That's all it sounds to me. Or, as you say, obstetric patients presenting with overwhelming hemorrhage, which is relatively rare.
Yes, so the emphasis was always very much on the priority was controlling the bleeding. Surgically is commonly the best way to do that, and that you won't get on top of the coagulopathies and the problems with circulation until you actually stop the woman bleeding. And that was always the priority.
Yes.
So I note the time. I'm about to move on to some different guidelines. I wonder whether now's a convenient moment to break.
We'll take a break now and come back at 11:45. Thank you.